Yeah, good evening, everyone, and sorry for the delay. So, being the last speaker, I'm here to talk about peripartum cardiomyopathy, and we'll be discussing about this case. So, I practice as a clinical cardiologist in Central Referral Hospital in Sikkim, and we had this 35 years old Sikkimese primary gravida lady who was not hypertensive, non-diabetic, non-smoker, and she had no history of alcohol intake and negative history, family history for CAD or CVA or sudden cardiac death. She had presented to some other hospital a month ago with normal vaginal delivery, and she got after a month to our hospital with complaints of breathlessness at rest, NYHA classification 4 for past 7 days, and for the last 3 days she also had orthopnea. On examination, she was extremely pale. Her blood pressure was 100 by 60 millimeters of mercury. She was tachycardic, low volume pulse with and regular. She was tachypneic. Her SpO2 was 85 to 89 percentage with 6 liters of oxygen. JVP was raised. She had loud P2 and chest revealed bibasal crepitations. Blood reports, her hemoglobin count was 8.4 grams per DL. Her kidney and liver function tests were all normal. ECG showed sinus tachycardia, and chest X-ray showed features of pulmonary venous congestion. This is a chest X-ray, bilateral pulmonary venous congestion. And then we took off echocardiography. So this is the normal echocardiography, as you can see here, with normal LV systolic function. But this is my patient's echocardiography, where you can see there's a reduced LV systolic function, and you can very well see the LV apical plot here as well. This is the same parasternal long axis view, where you can appreciate the clot, LV apical clot. This is another view. So this patient had mild TR, and her TR gradient was 45 millimeters of mercury. We managed her with oxygen. We kept her in a proper position. We gave her diuretics, IV furosemide. She was kept on dobutamine and noradrenaline support. And she was also given IV heparin and IV antibiotics. After stabilization of her vitals, she was started on ramipril, ACE inhibitor, and also levocarnitin. She was discharged on the 7th day of admission on oral furosemide, eplerenone, ramipril, oral warfarin, and levocarnitin. She came back for review after 2 weeks, and she had marked improvement in her symptoms with functional NYHA classification 2 to 3. Her echo was reviewed, wherein her ejection fraction had improved to 34%, and there was a reduction in the LV clot size. So again, she was followed up after 2 months, marked improvement in symptoms. Her review echo showed increase in her ejection fraction to 47%, and there was total absence of LV clot. Now she got well, and she's still on follow-up. She's doing well. Now coming to peripartum cardiomyopathy as such. So cardiomyopathy is literally a heart muscle disease. And when associated with pregnancy, what happens is the heart dilates and weakens, as we all know, and leads to symptoms of heart failure, arrhythmias, and even sudden cardiac death. Peripartum cardiomyopathy becomes quite difficult to diagnose because it mimics those of the symptoms mimics those of pregnancy, and progresses to severe heart failure, wherein at times patient requires mechanical support or even heart transplantation. Even when the heart recovers, another pregnancy may be associated with a risk of recurrent heart failure. But 50% of the patients may recover to a normal heart function, and they can be stabilized with medications. Now, to diagnose PPCM, there are 3 criteria. Number 1 is the heart failure should develop in the last month of pregnancy or within 5 months of delivery. Number 2, heart pumping function is reduced with an ejection fraction equal to or less than 45%, and there should be no other cause for heart failure with reduced EF. So this is the relationship of onset of PPCM to the time of delivery. As we can see, the first month post-delivery is very vital. Patients usually present at the first month. Talking about PPCM in the United States, 1 in 3,200 live births is seen, and 1 in 1,000 in South Africa, and 1 in 300 live births in Haiti. So, which basically means that in Haiti, the PPCM is like very common. The precise incidence in India is not known. 1 per 1,374 live births reported from a tertiary care hospital from South India. Most patients, that is 80% of them, present within 3 months of delivery, 10% presence in the last month of pregnancy, or 10% presence 4 to 5 months after delivery, which may be related to difference in diet, lifestyle, or genetics. The risk factors being older maternal age, multiparity, multifetal pregnancy, African descent, high blood pressure, prior toxin exposure, like drug abuse, like cocaine, use of certain medications to prevent premature labor. Now, coming to the cause of peripartum cardiomyopathy, the cause is not clearly defined, but heart biopsies have revealed inflammation in 10 to 75% of cases, or prior viral illnesses or abnormal immune response could be also the cause. Other potential causes are nutritional deficiencies, coronary artery spasm, small vessel disease, and defective antioxidant defenses. And there are 2 studies which support genetics, which may play a role. The rare variant genetic cause, which is similar seen in familial DCM, is at play. The clinical presentation is shortness of breath, fatigue, leg swelling, abdominal pain, bloating, weight gain, chest pain, cough, palpitations, tachycardia, or high blood pressure. So we evaluate the patient with, first you rule out the other causes of heart failure, rule out any other heart ailments, or if the patient is predated pregnancy, other potential cause of precipitants of heart failure, familial history of heart disease, other non-cardiac conditions associated, and other complications like thromboembolism. We send all the blood tests, like the routine blood test. We assess for kidney, liver, thyroid function, the electrolyte, CBC. We also have to send the cardiac troponin and the B-type natriuretic peptide. Other causes of cardiomyopathy like SLA and HIV, which we usually forget, we have to send those also. Chest X-ray, CT, EKG, echocardiography being the mainstay. These are all very helpful in diagnosing. And sometimes patient also has to go for cardiac catheterization. The role of management is basically to improve blood flow to vital organs, to reduce fluid overload, and to prevent or treat complications like blood clot formation and abnormal heart rhythms. So during pregnancy, early diagnosis and prompt treatment is vital. Severe forms of heart failure will require ICCU management, monitoring of ABP, central venous pressure, PAC, pulmonary artery catheter. Sometimes patient needs to be, they need to undergo PAC as well. And it's a coordinated management of multi-speciality team. And during pregnancy, ACE inhibitors and ARBs are contraindicated. Sodium restriction diet, loop diuretics, digoxin, vasodilators, these all required. Beta blockers, they have strong evidence of efficacy in heart failure. Now coming to postpartum period, during postpartum, we can start ACE inhibitors and ARBs, and diuretics, spironolactone, digoxin, beta blockers. And in beta blockers, metoprolol is preferred over carvedilol. Anticoagulation therapy. Due to high risk of venous and arterial thrombosis, anticoagulation with subcutaneous heparin is needed, especially for bedridden patients if the ejection fraction is less than 35%, atrial fibrillation, mural thrombi, or obese patients, and those with history of thromboembolism. Hypercoagulable state of pregnancy coupled with stasis of blood due to ventricular dysfunction makes them more prone for thrombus formation. Persist up to 6 weeks of postpartum. Heparin is advocated in antepartum period and warfarin in the postpartum period. We have to give them antiarrhythmic drugs as well. Quinidine procainamide should be tried first because of the higher safety profile. Beta blockers, like we have already discussed, and other drugs like digoxin. And if the patient has cardiac arrest or ventricular tachycardia with hemodynamic compromise, sometimes patient may also require ICD. So these are the medications for the treatment of PPCM in during pregnancy and after pregnancy. So as we have already discussed, the thing to note here is anticoagulation during pregnancy. We cannot use warfarin. We have to use heparin during pregnancy, and post-pregnancy warfarin is indicated. And also we have to remember that ACE inhibitor and ARBs are contraindicated during pregnancy. We can only start after pregnancy. There are newer treatment modalities like pentoxifylline, which is a xanthine derivative. It inhibits the production of TNF alpha and has been shown to improve functional class in LV function. Role of bromocriptine and carbogoline. Most recent few studies have suggested the role of prolactin breakdown products in the etiology of PPCM, and bromocriptine basically has more beneficial effects. And only a small study has been done on this. Immune modulating therapy, IV immunoglobulin, and plasmapheresis has also been tried. Other interventions and devices which are needed are patient may require IABP support or LVAD, ECMO support, or patient may also require AICD. Delivery and breastfeeding. Decisions on the timing and type of delivery. The decision is taken by a multidisciplinary team, including specialists from cardiology, obstetrics, anesthesia, pediatrics. Early delivery is not required if the mother and fetus are stable. In one study, preterm birth occurred in 25% of patients. Patients with PPCM may choose to breastfeed after delivery. ACE inhibitors, beta blockers, and diuretics are generally considered safe in this setting. We advocate for low salt diet and restricting fluid intake to less than 2 liters per day. Alcohol and smoking should be strictly avoided. Patients may be asked to weigh themselves daily and report significant changes. Activity level depends on the severity of symptoms, as we all know that. Now, prognosis and follow-up. Older studies have shown that 50% recover to normal heart function. 25% have persistently reduced heart function, but they remain stable. And other 25% they progress to severe heart failure. Recent research suggests survival rates at as high as 90 to 95% with contemporary medical and device therapy. Early improvement in ejection fraction, that is within the first 3 to 6 months, predicts a good outcome. The decision of when to stop medications, ACE inhibitors and beta blockers should be continued for at least 1 year after normalization of EF. So, as we already discussed, survival in patients with cardiomyopathy, 90 to 95% is survival rate. Now, risk of subsequent pregnancy, it depends on the recovery of heart function. Persistently reduced ejection fraction, patients have substantial risk of recurrent heart failure and even death. If the ejection fraction has recovered, then the risk is much lower, and it's further stratified by dobutamine stress echocardiography. Normal contractile reserve, the risk of recurrent PPCM heart failure appears to be minimal. Any decision to become pregnant again should be made after consultation with a cardiologist and an obstetrician. So, a recent large retrospective survey has shown that normal LVF, approximately 21% risk of heart failure. However, no serious complications were noted. Overall recommendation clearly being that pregnancy is avoided in women with persistent poor left ventricular function. So the take-home message is peripartum cardiomyopathy is potential life-threatening cardiac failure. Diagnosis should include echocardiographic substantiation of LV dysfunction. Role of endomyocardial biopsy in day-to-day diagnosis is controversial. Usefulness of diuretics, vasodilators, digoxin, beta blockers, and anticoagulation. During pregnancy, ACE inhibitors and ARBs should be avoided. In resistant cases, pentoxifylline, immunoglobulin, and immunosuppressive drugs may be used. Bromocriptine and carbogoline hold promise for the future. Severe cases might require advanced life support systems and even heart transplantation. Prognosis is linked to recovery of left ventricular functions. Subsequent pregnancies are associated with very high mortality. In patients with normal cardiac function on echo evaluation, subsequent pregnancy may be considered, but under close multidisciplinary supervision. I come to the end of my presentation. Thank you.